Secretary General of the Commonwealth, Excellencies, distinguished guests, ladies and gentlemen, I am honored to be giving the keynote speech at this important conference. As we speak today, and according to the latest edition of the Cancer Atlas, cancer remains the second leading cause of death globally, accounting for an estimated 9.6 million deaths annually. The issue here is that despite of the fact that there has been progress in supporting countries with the tools in facing off with cancer, especially in low resource settings, such as WHO's Essential Medical List, WHO's Best Buys, the comprehensive and updated cancer resolution, etc. However, the progress has not been considerable enough nor fast enough to halt the deadly statistic of 70% of global cancer deaths taking place in low and middle income countries. And that is even before the destructive effect of COVID-19. Many health systems in low and middle income countries, including commonwealth countries, are still the least prepared to manage this burden, and large numbers of cancer patients do not have access to timely quality diagnosis and treatment. Building the infrastructure for cancer care is a complex endeavor and takes time and significant resources. Low middle income countries were delayed in starting to lay the foundation for cancer care, whether in human resources or in physical infrastructure. When the global health community unfortunately long assumed that they were only burdened with infectious diseases, thus diverted all funding and support only towards fighting infectious diseases. As we speak, many countries have only just recently bought their first ever radiotherapy machine, for example. I actually have the one machine recently installed in Rwanda last year that will service more than 13 million people. The same goes for oncology doctors. Many countries have at times two oncology doctors supposed to service a whole country. I get it. It does take time to harvest the efforts placed now to be able to manage and treat cancer successfully. And that is why what I don't get is why countries are not placing an equally great focus on prevention and early detection then, so that they can at least stop the new avalanche of cancer patients. Especially for the fact that we now know that we can prevent between 30% and 50% of cancer deaths by modifying or avoiding key risk factors and implementing existing evidence-based prevention strategies. Some cancers, such as cervical cancer and hepatitis B and others, can actually be prevented 100% by vaccination. I'm not saying here to ignore treatment, not at all, as treatment remains important for the immediate and medium term. But what I am saying is that we have to work on all fronts, making sure that we attack cancer across all the cycles, blocking its door from wreaking havoc. Screening and prevention have to also have the same weight if we are to close the door to new cancer cases or to reduce late presentation, which is the death knell for cervical cancer. Yesterday was a big day. It was the formal launch of the WHO Global Cervical Cancer Elimination Strategy that countries signed up to, setting a bold target that by the year 2030 to have all countries achieving 90% HPV vaccination coverage, 70% screening coverage, and 90% access to treatment for cervical, precancer, and cancer, including access to palliative care. This is heartening news indeed. That is why I am so pleased that the Commonwealth countries are of the first group to hold a meeting on cancer prevention with a focus on cervical cancer right after, by so doing sending a clear message of hope to the 265,000 plus women presenting with new cases of cervical cancer each year in the Commonwealth, and saying that this time around we mean business. However, this strategy will only deliver hope to the thousands of women afflicted with cervical cancer who are desperately waiting for deliverance if countries and global partners actually start to implement it line by line. For those countries who are still dithering on serious action, they need to be reminded of what actually happens to the women in their lives, mothers, daughters, aunts, wives, friends, when they do contract cervical cancer and left to fight it without any ammunition. It is no exaggeration to say that it is an extremely painful and undignified way to die. The cervix enlarges, pushes into other areas of the body whilst emitting a foul odor and ultimately causing our women to bleed to death. I apologize for the graphic details, but if this is what it takes to spur serious action, then let it be. After all, we owe it to the estimated 570,000 women who are diagnosed with cervical cancer annually and about the 311,000 women, 70% of which from our countries, low middle income countries, who die each year without having the chance to fire a single bullet against cervical cancer. In stark contrast, in a high income country, the narrative would be totally different. Chances are that if a woman were to contract cervical cancer, she would have been diagnosed through her regular annual pap smear exam, more likely that she would be early detected, and then she can expect quality treatment and hopefully cure. Most women in high income countries would be given the best chance to live to see another day. That is not to say that there can be also inequalities within high income countries. One would somehow swallow it a bit more if cervical cancer was one of the difficult ones to handle. However, we are talking here about a disease that can be prevented, early detected, and treated. We have all the tools to eradicate it, even, and therein lies the tragedy of it all. Cervical cancer is the one example that best exemplifies all the gaps and faults in our current global health system, but also exemplifies the opportunities in showcasing how we can change the deadly trajectory for cervical cancer. Cervical cancer bridges the non-communicable diseases, NCDs, and communicable diseases, CDs, categories, and yet it did not even get the attention it deserves, neither as an NCD nor as a CD disease, even for the fact that HIV patients are twice as likely to get cervical cancer and die from it than any other segment. Cervical cancer suffered the fate of the either or dichotomy between diseases, the building of vertical systems that would treat diseases rather than patients, a health system that invests time, money, and resources to reach out to HIV women, for example, and treat them, and yet miss that great opportunity of interaction with those same women to be early detected for breast and cervical cancer, for example, or to vaccinate them. Noting here, again, that HIV women are twice as likely to contract cervical cancer than any other group. This is what vertical systems do. They reduce actual human beings to diseases or donor projects. Vertical systems not only squander lives, but also efforts and scarce resources. Cervical cancer also highlights the sheer inequality of action. Cervical cancer is not only synonymous with women, but also poverty. It is predominantly the poor and marginalized women who die from cervical cancer. So I believe that if governments hope to succeed in rolling out the strategy for the elimination plan, they have to realize that they have to fix the flawed, inefficient fundamentals that currently belie our health system first. They have to veer away from the vertical siloed approach to a diagonal one. For example, it cannot be so difficult to think of integrating vaccination programs of cervical cancer as part and parcel of general vaccination programs. It really is not rocket science to do so, or to integrate reproductive health services with HIV and cervical cancer services, whilst making sure that adolescent prevention and screening services tackle all. It is doable. And now that we have the political will, we also have to have the will to decide to have a fresh new look at our actual fragmented health and donor systems that we have inherited for so long. And I emphasize the word system here. Health and medicine is not just about a doctor with a black bag after all. It's a complex web of systems and processes. It is actually a health care delivery system, as quoted by Professor Siddhartha Mukherjee. The fact that measly 50 cents protective masks became a crucial obstacle to the fight against COVID-19, reminded us all that health is indeed as much about supply chains as about expensive medications. The same goes for cervical cancer vaccinations. Many countries who had the political will and great intentions and actually prepared the ground for vaccinating their girls, only to have their efforts halted due to global vaccine supply issues or when donor money ran out, thus negating the efforts completely. Also, countries who failed to prepare the ground with intensive awareness for a successful uptake of the vaccination failed to deliver their goals. The responsibility for a successful rollout of the cervical cancer strategy lies in having sorted out prior the known barriers, such as by establishing the relevant global partners needed, such as by Gavi, World Bank, and others, by including strategic funding and supply agreements to guarantee affordable prices and reliable vaccine supplies that is not dependent on unreliant NGO funding. Also, we need to make sure that we have the support of organizations such as the Union for International Control, which I was president of, which is a powerful global membership organization for reducing the global burden of cancer, and UNITAID, an engine of health innovation, for example, who are joining forces to strongly endorse WHO's inspiring targets to help secure their achievement. We simply need all hands on deck. The political will to roll out a successful strategy is not just on the country level, but also on the global level, as they are both intertwined. Cervical cancer elimination push represents a great opportunity. It could very well be the engine that will help test and deliver the changes in our health systems that have long evaded us, thus paving the way for a more efficient health system that can also deal with other cancers and other non-communicable diseases, as well as preparing the ground for successful implementation of universal health coverage. Today, I join the Commonwealth in advocating for collective action in cancer prevention and cervical cancer elimination at the next Heads of Government meeting in Rwanda. In the Commonwealth, you have the chance to do something really significant for leading the world in committing to the specific town-bound solution. The Commonwealth could very well be the example of the little engine that could. Thank you so much for hosting me and letting me give you the keynote speech. Thank you.